I understand that the way that I practice pediatric cardiac critical care is going to be a very different construct from the way that you practice it. So feel free to raise your hand and interrupt and ask any questions, or if something seems like it's not relevant to your practice, please do let me know, because then we'll skip right ahead. And I'm not talking about things like ECMO. It's just, I take care of patients from the time of their birth to the time of their discharge. So preoperatively, postoperatively, and then all the way to their discharge, they are under my care, or myself and my partner's care, which is, I think, a different construct from what you practice. So I see the continuity, and which makes it, for me, easier to determine how I tailor my practice to the needs of the patient. So in the next probably 30 to 40 minutes, what I'm going to try to do is to give you an idea of how I practice pediatric cardiac critical care. So I'm going to start with the first thing that I do with every single patient on my unit. As I'm getting sign out from the night shift team, I classify them, I put them mentally into one of these 4 boxes. Now, this is probably what all of you do, consciously or unconsciously, to determine which patient is going to need immediate care and which isn't. I'm not talking about the patient who's actively arresting, or you're resuscitating or giving fluid boluses to, but then it's the rest of the patients who you don't know where you have to round on first, and then you have to triage your patients mentally in order to determine which patients need your attention first and who doesn't. So, the first one is the patient who is warm and dry. And all of this is the state of the systemic vascular resistance that you're actually assessing, right? So a warm and dry patient is a patient who is on the perfect point of the Starling curve and has the perfect degree of vasodilation and has adequate cardiac output with no degree of compensation required. So this is your patient who's on their trajectory to going home. You might have to do a few things, but usually I ignore those patients and let other people take care of it, which might be my trainees. So you might have to take care of the things which I ignore on these patients, but at least they don't need your immediate attention. And then you have the patients who are still adequately perfused, whose SVR is still not elevated, but they still have a state of, they're fluid overloaded. So you just have to adjust the point on their Starling curve at this point. So might need some minimal adjustment of diuretics. Easy to do. But again, if you allow that state to move on, they then move on to the next phase of shock, which would be cold and wet, which means that they are fluid overloaded, and now they've begun to have an increased SVR state in order to compensate for those patients. So these patients are the ones that require diuresis. I usually use milrinone in these patients and PRBC transfusions in order to increase the mixed venous saturation. So again, still manageable patient. Now, the scariest of all is the cold and dry patient, where you have an elevated SVR and they're in an adequate state of volume. So they're probably euvolemic. The Starling curve is exactly where you want it to be, but the patient is still in an inadequate cardiac output state, which means that this is the patient that you really have to think about. They are probably, if you neglect this patient, is probably pre-arrest. And sometimes, even if you don't neglect the patient, and you are at their bedside trying to resuscitate, these are the patients that are the scariest of the lot, because you don't have that many options. So here is where you start ramping up inotropic support, whether you use epinephrine or milrinone, all of these, and you're ramping it up, and you're standing at this patient's bedside to determine what the results of your interventions are going to be. So that's the scariest patient of all, and that's the patient who I usually go to first to assess and then determine what they're going to need in the next 15 to 20 minutes, walk away, assess the other patients, and come back and see what the results of your intervention are. So for me, this construct works because I'm able to then take my entire unit and put it in one of these 4 categories to then determine which patients are going to require immediate care and which aren't. When the Manny Rivers study came out about goal-directed therapy for sepsis, it sort of revolutionized thinking in all faculties of medicine, where a lot of times we say, oh, this patient is breathing fast, let's just increase high flow. Oh, now that didn't work, let's just intubate. But you have to take a step back and look at the bigger picture. what are your ultimate goals for the patient? So for the postoperative pediatric cardiac patients, this is how I think about it. And again, these are not edicts. This is merely the way different people practice. This is what I think about in every single postoperative cardiac patient who walks into my unit. The first thing, of course, is optimizing cardiac output. This is going to look different in the immediate postoperative phase. So in the first 2 to 3 days of the postoperative phase, it's going to be very different from what the next few days to weeks is going to look like, or in the preoperative phase as well. How do you optimize cardiac output? And that's something which you have to determine depending on what the lesion is, depending on what the state of the patient is. The next thing that everybody should be doing is early extubation. So this is, obviously extubation increases length of stay, increases mortality, increases morbidity. And the goal of every patient should be to extubate as early as possible, which I'm sure all of you do. But if you fail to extubate, it has to be a very thoughtful segmental approach to why the patient is failing extubation. Does the cardiac lesion itself explain why there is a failure of extubation? If the cardiac lesion does not explain it, is there a respiratory reason? Is there an anatomical reason? Is there a neurological reason? Are there other extra cardiac defects which are contributing? Or if it's a postoperative patient, are there residual lesions that are present that we're missing? And is that what is precluding early extubation? The next aspect of this is management of acute kidney injury. Now, acute kidney injury is universal in every cardiac patient. Every single cardiac patient who goes through bypass or through cross-clamp is going to have some degree of renal compromise. And the question is, in fact, in 2022, there was a recent study which spoke about what acute kidney injury in the cardiac patient even means. We know they all have renal injury, but if it starts to affect your patient's outcome, that's when it makes a difference. And how do you manage those aspects of renal injury? And the other aspect of it is early enteral nutrition, which of course everybody here does in a fantastic, phenomenal way. We have those bad habits of starting TPN where it's not required, starting TPN for 2 days, which you guys absolutely don't have and you shouldn't have. But early enteral nutrition is one of the most important aspects of preoperative care, operative, postoperative. If you can feed the child and grow them and keep them in a positive nitrogen balance, get them to gain some degree of weight or at least not lose weight, that makes a huge difference to outcome. So for my postoperative patients, these are the 4 categories under which I think of them. These are the goals of care for each of these patients. So I can talk in detail about all of these, and you feel free to interrupt me at any point to ask any questions if you should have any. Okay, I'm sure everybody knows this. This is the Fick equation, which we use for assessment of cardiac output. Oxygen consumption is cardiac output and into arterial oxygen minus venous oxygen content. So here is something which, many times when you have a postoperative patients, there are hemodynamic parameters that you're looking at, correct? And what are the hemodynamic parameters that you look at when you have a preoperative or a postoperative patients? What do you look at when you look for adequacy of cardiac output? What are you looking at? Don't make me pick on you, because I will. What do you look at when you look at your patient when they come in? When you want to say, oh, this patient is in shock, this patient is not in shock, this patient is adequately compensated, is not adequately compensated. You looked at me, so what are the parameters that you look at?
Heart rate, CFT, blood pressure.
Sorry, what is CFT? Okay. Okay, and you said blood pressure, right? So, when you look at the equation for cardiac output, it's stroke volume into heart rate, okay? And stroke volume is dependent on preload, afterload, and contractility. Nowhere in that equation does blood pressure actually, thank you, does blood pressure actually come out. So the reason I'm saying this is because, when your goal is cardiac output, that goal is not truly always blood pressure. Okay, and what you mean by that is that when you try to estimate cardiac output, when you're actually doing tissue hemodynamics on a patient, say you took every single patient who is up in your unit to the cath lab and tried to get an accurate assessment through Fick measurements of cardiac output, the parameters that we often use to determine how we're going to resuscitate them are not always in concordance with what the cardiac output is. For example, say I have a patient who is DTGA, who is status post an arterial switch procedure. Okay, now those patients, I actually lower the blood pressure, I'm lowering the SVR, right? I'm lowering the SVR in order to increase cardiac output. So keeping in mind the lesion that you're treating, the outcome that you want, which is, it's not as simple as I want a heart rate of this and a blood pressure of this in order to keep my patient well perfused. You actually have to measure, and I like capillary refill and feel the patient. Are they cold? Are they warm? What is the cap refill? Are they now in a state of vasodilatory shock, and am I supposed to use pressors on them in order to improve their perfusion to the kidneys and to the brain? Because that's what ultimately tissue oxygenation is the goal. And tissue oxygenation is not blood pressure. And I cannot emphasize this enough, because sometimes, we receive patients who come to us from outside who have been resuscitated with really high doses of norepinephrine in order to maintain a particular perfusion, and they're cold and they're almost necrotic in the process, but blood pressure is not cardiac output. Okay? The other determinants of cardiac output, of course, are heart rate. And the three things that the three factors that stroke volume depends on are preload, afterload, and contractility. Out of that, the ones that we can most easily manipulate are the preload and the afterload. Contractility is an intrinsic function of the pump, and you can do some things to change it, but otherwise, the Frank-Starling curve for that patient is going to be what it is. There's not much you can do. What you can do is figure out where exactly you want that Frank-Starling curve to be for this particular patient. For instance, in a patient with, say, tetralogy of Fallot with severe diastolic dysfunction, the filling pressure, you're going to need a filling pressure which is much higher, because that is a thick, non-compliant ventricle that requires a higher filling pressure and is going to require more preload. Contrast that with a patient with, I won't say dilated cardiomyopathy, but say a switch procedure, a DTGA whose status post a switch procedure, which is a thin-walled, dilated left ventricle, which now is probably going to need a CVP close to 2 to 3, a single-digit low CVP in order to maintain the stroke volume. So what I mean is, these patients require individualized care. It is not one formula fits all. Each patient will tell you what CVP they want, what sort of blood pressure, what sort of heart rate they need, and you have to listen. And the problem with this is that state changes. But as they go into worsening heart failure, they're going to tolerate less manipulations of preload and afterload. As they improve, you can back off and let them do what they want. The key is to follow their own trajectory and to push them until as far as they will allow you to push them in order to meet the goals that you're going to ultimately require. We all know that cardiopulmonary bypass is bad for patients. Okay, I mean, it is, of course, we've made enormous strides in the way that cardiopulmonary bypass, I mean, in fact, if I think of the single most important development that has come about, it's the duration of cross-clamp, it's the way in which they administer cardioplegia, which makes it so much easier for me as an intensivist to take care of the patient. However, it still holds true that cardiopulmonary bypass induces an inflammatory response. They will cause a fluid overload state. They will cause a capillary leak syndrome. It will cause and it does cause a significant degree of diastolic dysfunction. And diastolic dysfunction, as we all know, is much harder to treat than systolic dysfunction. So cardiopulmonary bypass is bad. All you can do as intensivists is support the patient through those phases when they feel the effects of the cardiopulmonary bypass. So usually we say something like 6 to 12 hours post-bypass is when your patients will require the maximal amount of attention in order to deliver the optimal output for that particular patient. So, but the magnitude of response to cardiopulmonary bypass is dependent on how you send the patient in. Intraoperative factors such as duration of bypass, your surgeon's skills, and the genetic variances. So out of these, what we can determine is how we send a patient in to cardiac surgery. Okay, so, and I saw that there were a lot of preoperative patients in your ICU, and the way that the better shape that you can send a patient into the surgeon, the more they'll thank you, because those patients are going to, if you can send in a transposition baby, PO feeding, extubated, with a little bit of nasal cannula, on maybe, yes, or plus or minus PGE, depending on what the status of their atrial septum is. If you can send that patient in that state, that patient is going to recover probably in 3 to 4 days. We've discharged babies post switch procedures in 4 days. Of course, a lot of that is the skill of the surgeon, but also when you send in a happy, healthy, fat, well-nourished baby into surgery, those patients are going to do much better than an intubated, sedated, paralyzed, NG-fed, TPN. All of those factors are going to raise the bar against you when you finally have to take that patient back for postoperative care. So the way that I, in broad categories, think of the postoperative care of the patient, like I said, care has to be individualized, but in very general categories, I think of it as right heart disease and left heart disease. Now, the classic example for right heart disease that all of you take care of is tetralogy of Fallot. And the classic example for left heart disease that all of you take care of is going to be transposition with status post a switch. So depending on my inotropic strategy changes, my time to extubation changes, and the volume status and the volume resuscitation that I will allow these patients is going to change depending on whether it's right heart disease versus left heart disease. So for diastolic dysfunction, for instance, we can go back to tetralogy of Fallot. So you know that the tetralogy of Fallot has the classic 4. I'm not going to go over that because I'm sure you all know it. But you have a very thick ventricle which is extremely stiff. So when you have a stiff, non-compliant ventricle like that, they are going to need higher filling pressures. But be very careful. So it is my rule that nobody is allowed to give a fluid bolus to my patients without actually going and pushing on the liver. I have the luxury of having an invasive arterial line, so I can see what the arterial line does and I can see what the CVP does in response to a fake fluid bolus, which is me pushing on the liver. But if you don't have either of those, sometimes when we get called down to the ED for a very sick patient, I will not allow a fluid bolus until I push on the liver and see what it does to the heart rate. If the heart rate comes down, then I can give fluid safely to that patient. If the heart rate, on the other hand, goes up and the patient's perfusion looks worse, then I do not give fluid. So you have a little more leeway in terms of when you have significant diastolic dysfunction and a thick ventricle, because these patients can tolerate, and they require higher CVPs, at least in the initial postoperative period. For tetralogy of Fallot, we use a combination of epinephrine and vasopressin, and we use, I don't have chalk, but we utilize something called the ANREP effect, ANREP. So what the ANREP effect is an acute increase in SVR increases right-sided cardiac output. Okay, so it alters. So the right ventricle and the left ventricle, the fibers are completely different. The orientation of the fibers are completely different from each other. There is a septum in between, and depending on the orientation of the septum, there's ventricular interdependence. The function of the right ventricle depends on the function of the left ventricle, and the function of the left ventricle depends on the function of the right ventricle. And it's not just about the amount of cardiac output that's generated. It's also the way the two ventricles interact with each other in terms of the septal orientation. So when you have patients who have right-sided disease, if you increase the SVR acutely, it has been shown that both acutely and for about 24 to 48 hours, you can increase cardiac output of the right side. Okay, so that's the rationale behind using vasopressin in these patients with tetralogy of Fallot and other right-sided lesions as well. Now, as they get over their initial postoperative phase after the first 24 to 48 hours, we then move on to milrinone for diastolic dysfunction. But initially, these are the two drugs that we use. And then if it's right-sided disease, we move absolutely towards extubating them as early as possible. And we can talk about that when we talk about the other cardiopulmonary interactions. When you have systolic dysfunction, and I'm going to use the classic example of post-op TGA, the strategies that we use are lowering the SVR, like I said, and we use any and all tools that are on hand. Milrinone, of course, is always available. We also use all of the nipride, nicardipine, all of that to lower your SVR as much as possible to maximize cardiac output. We use epinephrine, and epinephrine is such a beautiful drug, right? Like at low 0.02 micrograms per kilogram per minute, it has a beta-2 effect, so it has a beta-2 agonist, and it'll lower your SVR while providing chronotropy and inotropy. As your doses increase, it provides mostly chronotropic and inotropic effect, and at much higher doses, as the doses that we use for cardiopulmonary resuscitation, it acutely increases SVR, and that's what we use it for in cardiopulmonary arrest. So usually those are the medications that we use for systolic dysfunction and particularly left-sided heart disease. Those are the drugs that we use. And again, I will talk about, I'm much more careful about extubating a patient with with left-sided heart failure, depending on what I think their trajectory is going to be in the next 12 to 24 hours. But these are the ones that I actually stop to think about it and say, am I brave enough to extubate this patient, say, at 3 a.m. in the morning when I don't have anybody else around me, or am I going to wait for the morning and see how this patient is going to do? So I just wanted to add this caveat. Of course, you have mixed lesions, like say a VSD, which should be a primarily systolic left-sided disease, but then say you presented late, and now the patient has had lungs which have been flooded for their entire life, and now has developed pulmonary vascular resistance issues. And I don't know, do you have inhaled nitric oxide available in the unit? No? Do you have sildenafil? They have it in the post-operative unit. Because, I do remember we were when I was in South America once, a lot of these patients, before they even go into the OR, we would give them a dose of sildenafil, because you anticipate that they come back with pulmonary vascular reactivity. And of course, when at the point of crisis, it's epinephrine, more epinephrine, and whatever it is that you can do to try and increase cardiac output. Because once you reach the point of PVR crisis, unless you have immediate agents like nitric oxide and other agents on hand, the only thing you can do is try to increase cardiac output and alter the orientation of the interventricular septum, push it towards the right, and increase cardiac output that way. The other important thing, since you take care of a lot of TETs, is that you have to make sure that that the patient is in sinus rhythm. I don't know if you've seen tetralogy of fellow patients with the junctional ectopic tachycardia. So TET, SCED, JET is something that all the baby nurses in our unit are supposed to learn and keep in mind. And I don't know if patients come back with epicardial pacing wires, because sometimes JET can be really hard to identify, because it can look very much like sinus rhythm, and you've lost 30% of your cardiac output. Your patient is now cold and rapidly on its way to dying unless you do something about it. My fail-proof method of diagnosing JET is to not look at the EKG at all. I just look at the CVP. So JET, of course, is when the junction becomes faster than the sinus node. So then the junction is firing at a faster rate. So now you have your atria that's contracting against a closed tricuspid valve. So you have Cannon waves on your EKG. So if you see Cannon waves, that patient has JET, whether you diagnose it through an EKG or not, and that's what I typically use. If the rate is low enough, then you can use the temporary epicardial wires to pace them out of it. If not, I use amiodarone. There are a lot of drugs that are available. I don't know what usual antiarrhythmics are available for you guys, but for us, I use amiodarone unless I have to use anything different. Now we move on to the next phase, and that's early extubation. I'm sure all of you know this. Spontaneous ventilation is negative pressure ventilation. And as soon as you intubate a patient, all mechanical ventilation is then positive pressure ventilation. So this is why children should be taken care of by pediatricians, right? They are nothing like adults. So these are all the reasons, and you can read them, and I'm sure you all know all of these reasons, that infants particularly have less respiratory reserve. We all know that. They react nothing like adults. Particularly with heart failure, I think the last study was there's something like a 30 to 50% chance of cardiac arrest just by the act of intubation of an infant with diminished cardiac reserve, which is not the case with adults. So you don't take that very, it's not a decision to be made lightly. So these are all the reasons that infants have diminished cardiac reserve, and then you add the component of cardiopulmonary bypass. And once you put a patient on bypass, you take all of those reasons and then you top it off with all of these reasons to make them fail. So just to show that every time you guys intubate, extubate, you do all of these things, you are actually thinking of all of these factors and you're balancing all of these factors while you're taking care of those tiny little babies that you see. This is what you're doing every single time that you're taking care of them. Okay? So the way that I think of cardiopulmonary interactions is right ventricle, left ventricle, effect of spontaneous ventilation on the right ventricle and intubation on the right ventricle, and the same with the left. Preload to the right, afterload to the right, preload to the left, afterload to the left. So in a spontaneous breath, as you know, it's negative pressure ventilation. The right atrial pressure decreases, abdominal pressure increases, the diaphragm goes down. So the venous return increases and it increases cardiac output. So for the right ventricle, spontaneous ventilation is the best. On the other hand, when you put in mechanical ventilation, you have increased RA pressure and decreased venous return. So the next aspect of it is right ventricular afterload, which is determined by pulmonary vascular resistance. Left ventricular afterload is determined by a number of factors, not just blood pressure. Left ventricular afterload, just as an aside, is one of the most complex concepts. So LV afterload is determined by the thickness of the ventricle, the cross section of the aortic root, the SVR, all of those factors together, and the complex interplay of extracardiac factors, all of these determine what left ventricular afterload is. So it's not as simple as SVR is left ventricular afterload, but we can talk about that later. Right ventricular afterload is determined by one thing only, and that is the pulmonary vascular resistance. So this is another one of my favorite graphs. So this is a graph of pulmonary vascular resistance against lung volume. So, while it's most important to have, I do want to extubate every single patient who has right-sided heart disease. However, one of them might have a huge pneumonia, or they might have complete right lung atelectasis, and they might need some positive pressure. The important thing is to maintain FRC, and FRC, because if you have lung collapse, your PVR increases. If you over-distend the lung, PVR increases. So even when you intubate the patient, what you have to keep in mind is that you have to keep them in a state of the lowest possible FRC that you possibly can. And that is when your PVR is the lowest, that's when your cardiac output from the right side is the highest, and that's when your cardiac output to the left side is also going to be the highest. LV preload, of course, is determined by RV afterload, RV cardiac output. Decreased RV preload will decrease LV preload. Increased LV afterload, RV afterload will decrease LV preload. And then, of course, as the RV starts to fail, the LV starts to fail. Okay, so that's how the left ventricle and the right ventricle play with each other and with spontaneous and mechanical ventilation. Now, this is a really important concept, and this is why we were talking about what happens with post-operative patients after a switch of procedure. So when you, and I'm sure all of you already know this, so this is the concept of transmural pressure, and the transmural, the wall that we're talking about here, is the left ventricular wall. You want the least amount of tension across the left ventricular wall in order to generate maximal cardiac output. So none of this makes a difference in a spontaneously breathing, normal cardiac output person, you and me, any child, none of this matters. However, in a person with diminished cardiac output, where the systolic function is reduced, all of these factors then come into play. So, for instance, when you have quiet breathing and if your in pleural pressure is 0, then the transmural pressure is 100 minus 0, which is 0. Say you have upper airway obstruction. Say your patient then starts to take exaggerated breaths and you're increasing the negative pressure to minus 25. Now your transmural pressure becomes 100 minus 25, which becomes 125. So now the work that ventricle has to perform becomes exponentially higher, and every degree makes a difference in these patients. So Then you intubate the patient and you give them a PEEP of 5, then it becomes 100 minus 5, 95, or you give them at even higher pressure, and so then your transmural pressure decreases. Okay? When you add vasodilator therapy, of course, when you lower your SVR, your transmural pressure decreases as well. So what I'm trying to say with this is that mechanical ventilation is your friend in severe systolic LV dysfunction. Okay? So now I'm going to also turn that around and tell you that when the cardiologist will come to me and tell me, you know what, the switch that we just did, the LV function is horrible. The LV is barely moving. I would keep this patient intubated for 2 days. I say thank you and then promptly extubate about 6 to 12 hours later, depending on how the patient is doing. And the reason I'm telling you that is because the echo doesn't tell you what to do. The patient tells you what to do. You go and see what the trajectory of the patient is. The adaptability of these patients is remarkable. And in mouse models, when they do an arterial switch procedure, within 6 to 12 hours, there's already remodeling happening of the left ventricle, and they can tolerate much more than you can imagine. So again, make sure there's FRC. So I need a clear chest X-ray, and I need to make sure that the inotropic support is on the weaning side and not on the escalation side, and it's still okay. But you have to know what you're doing. You have to anticipate the complications. These patients can have a cardiopulmonary arrest when you extubate them, or they don't have to arrest immediately. They can slowly start dwindling, and then then when you intubate them, they could have a cardiopulmonary arrest. Some of these patients are impossible to bring back without ECMO support. A lot of the times, if I have to start CPR on these patients, I automatically activate ECMO, which is not a luxury which we have here. So all of these decisions have to be made very thoughtfully. Usually when I'm extubating these patients, I will also have my nurses draw up doses of bolus epinephrine just in case I'm anticipating the arrest. And sometimes I'll dilute the epinephrine to a factor of 10 and give small bolus doses of epi, but not the whole thing, and see what we can do. Okay? So just to be careful with what you're doing when you have your patients with systolic dysfunction. So the key points of cardiopulmonary, and again, this cardiopulmonary interactions is probably a 2-day lecture on its own, so I'm really abbreviating it and trying to rush through it, but just know that these are the key points. Systemic venous return to the right atrium is the most important determinant of RV preload and RV cardiac output. In healthy people, spontaneous and mechanical ventilations don't really affect the left heart much. They affect mostly the right heart by altering the PVR. Any change in lung volume from FRC will result in an increased PVR. So make sure that when you're ventilating a patient, you're ventilating them at FRC. Negative intrathoracic pressure. And again, these are the patients. So say you have a tiny little switch baby with DTGA who you've extubated, and then immediately afterwards they develop stridor. So what happens when you have stridor is you have exaggerated negative intrathoracic pressure. So when you have negative intrathoracic pressure, the transmural pressure across that LV exponentially increases. So all of the factors that play against you to get them to the extubated state are going to continue to be against you as you take them through the crucial 4 to 6 hours after extubation. Okay? So you have to be very careful with these patients. And positive pressure, whether invasive or non-invasive. A lot of the times, we have dilated cardiomyopathy patients who will go home on just BiPAP if there's sort of end stage or if they have nothing else, and that almost acts as another inotrope or a ventricular assist device. That's the enormous effect, the usefulness and the effect that positive pressure ventilation has on left ventricular failure. Okay, now we move on to kidney injury. Like I said, most patients develop some degree of AKI. You have different criteria. One of the criteria that has been used more commonly is the pre-rifle criteria, and it tells you about the degree of renal injury following cardiac dysfunction. So worsening AKI independently is associated with systolic dysfunction. Now, what does that mean? We all know that post-operatively, after a patient goes on bypass, after a patient goes through cross-clamp, the renal the renal function is compromised. Now, whether the creatinine goes from a baseline of 0.3 and doubles to 0.6, or whether it goes up to 1 or 1.2, and whether you have zero urine output, it just depends. There are varying degrees of renal dysfunction. What we do is you could use a test dose of Lasix, which is you give a bolus dose of maybe 2 milligram per kilogram of Lasix, see if the patient has any urine output. If they do, you can start your Lasix infusion. I did see you use Lasix infusions, right? Yeah, we are pretty aggressive with diuretics. So the problem with renal injury is that renal injury causes fluid overload, which causes renal injury, which causes fluid overload, and then you can't extubate your patient. Everything just falls apart, right? So, and this is a very interesting statistics. There's increased mortality beginning at fluid overload with more than 10%. And with each 1% increase in fluid overload, there's a 3% increase in mortality. So it's absolutely essential that we get rid of fluid in any way that you can. Particularly in infants, though, there is another concept of renal venous hypertension, where you could have different reasons for your CVP being high. And because your CVP is high, the patient's renal venous pressure is high. And when the renal venous pressure is high, that worsens cardiac injury, okay? So in the adult studies, the magic number was found to be between a CVP of 9 to 12. That's not true at all in pediatrics. Sometimes if I'm not able to diurese the patient, I'll increase the mean arterial blood pressure to much higher to maintain a renal perfusion pressure that's adequate to make some urine. Also, babies come back with ascites. They can come back with abdominal compartment syndrome due to a variety of reasons. And when renal, arterial, and venous blood flow is compromised, you're going to have worsening renal injury again. So just putting in a PD drain, you don't even have to use it for peritoneal dialysis. If you put in a PD drain and drain that fluid out, just relieve the pressure and relieve the renal venous hypertension. That itself can increase urine output exponentially. So make sure that we don't get fluid overloaded as much as we possibly can. Nutrition, I don't have to teach you because you all are really good at it, but feed the baby, feed the baby, feed the baby. Enterally feed as much calories as you will tolerate. The only thing that I will say is to have possibly, and I don't know, do you have feeding protocols in place for post-operative feeding and things like that? Because feeding, just to make sure that a nurse doesn't say, oh, okay, here, feed the baby and start feeding 2 hours post-operatively and then the patient vomits or then develops necrotizing enterocolitis. Just have protocols in place. Make sure that you feed adequate nutrition, adequate calories, weight gain. This is the single most important thing that we could do outside of all of the medicines and other mumbo-jumbo that we play with in order to deliver optimal outcomes.